Hey, all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. We've got the free 31-page PDF, top 200 drugs, great study guide, great refresher if you're out in practice or if you're a student preparing for board exams and pharmacology exams. Simply an email will get you access to that. And then we've also got updates when we've got new free stuff available, as well as some of our paid content as well. So again, no-brainer to go get that. Simply an email will get you access to that top 200 study guide. All right, so we are going to cover tricyclic antidepressants today. I'm going to cover some of the most important things you see in practice, as well as things that show up on board exams. So tricyclic antidepressants, as it sounds, they are kind of classically used as an antidepressant. They were the mainstay of therapy prior to the advent of SSRIs. So at this point, it is an older class of antidepressant medications. They are still used clinically. But I will say, it's most often when we've got a compelling indication or we've got a patient that's refractory to other antidepressants. So in addition to depression, certainly can be used for neuropathic pain, as well as migraine prevention. Those are the two major indications I see it used for. Occasionally you see some insomnia use. Usually that's lower dose doxepin. I'll talk about that coming up. Rarely for other pain type syndromes, maybe a refractory OCD case, those type of things. But again, usually we have some sort of compelling indication to use these antidepressants other than depression. So again, likely neuropathic pain and migraine prevention are probably two of the most common that I see in practice. All right, listing off the most common agents within this class. There are some rare and obscure ones that I'm not going to talk about that I never see. But main ones, amitriptyline, nortriptyline, imipramine, desipramine, clomipramine, and doxepin. Now, mechanistically, how do these medications work? And I do lump them in a little bit with the SNRIs, with the caveat is they do more than inhibit the reuptake of serotonin and norepinephrine. So that's really where they start. Again, that inhibition of serotonin and norepinephrine, so that differs a little bit from the SSRIs, so your sertralines and things of that nature. Now, in addition to blocking that reuptake of serotonin and norepinephrine, they also can block histamine receptors. They also can block muscarinic receptors, alpha receptors, and have some cardiac effects as well. Now, the clinical significance and how much each receptor is bound and activated and blocked, that can really cause variable effects within the body. So it explains, the norepinephrine piece along with serotonin explains why it can be used for neuropathic pain, just like SNRIs. The antihistamine type effects, like with doxepin, for example, that explains why they're pretty sedating. So these effects, they all kind of blend and blur into, and that receptor binding helps us understand why, this one causes a little bit more sedation versus this one causes a little bit more QTC prolongation, for example. And I'm going to go into those individual differences and some of the most important things coming up here in a little bit. Structurally, so I want to talk about the chemical structure very, very briefly. Just understand that there are tertiary amines and secondary amines. So essentially what that means is it's going off of the number of carbon-containing groups attached to the nitrogen atom in the side chain of the molecule. Okay, so tertiary, there's 3 carbon groups. Secondary, there's 2. Okay, so that's basically where that differentiation is coming from. And Tertiary amines, the examples, amitriptyline, imipramine, clomipramine, and doxepin, they tend to be a little bit more serotonergic in their action. So that's kind of an important differentiating factor. Maybe a little bit more anticholinergic and sedating as well. So, that's really the tertiary versus secondary amines, just recognizing that, drugs within each of these categories may have a little bit more specific effects because they bind certain receptors differently. And then the secondary amines, nortriptyline and disipramine, these tend to be a little bit more on the norepinephrine side. Maybe a little bit better tolerated, maybe not quite as dirty, if you will, on the anticholinergic side and things like that. And nortriptyline, I would say specifically, is the one I see preferred in older adults if a TCA needs to be used, again, because maybe we have a little more tolerability there. Now, you compare, nortriptyline to maybe a standard SSRI. I'm probably, as far as tolerability, I'm probably going to pick the SSRI in that case. And this is why, these medications, TCAs, aren't used first line for depression anymore. All right, let's talk quickly class side effects. And I want to mention anticholinergic adverse effects, just a good reminder, dry mouth, and I think of this in the world of polypharmacy and the prescribing cascade. So when you see a prescription for saliva substitute, because patients are complaining of dry mouth, pay attention to anticholinergic medications like TCAs. Another one, if you see, Senna, Miralax, laxative type medications ramping up, that patient's having constipation. Definitely could be due to one of these medications. Urinary retention, if you see a prescription for Flomax or other BPH type medications, again, anticholinergic effects. Blurred vision, dry eyes, artificial tears, restasis, again, could be caused by these medications. Worsening confusions is another one as well. So if you see dementia medications being started because patients are more confused, that could be due to anticholinergic effects. And in my patient population, I deal with a lot of older patients. This is way, way more important typically than somebody who's 35 years old who probably doesn't have as much trouble tolerating these medications. All right, let's take a quick break from our sponsor, and then we'll talk about individual medications. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, Naplex, or others, go check out meded101.com/store. We've helped thousands of pharmacists prepare and pass their board exams. We've had a 10-year track record of creating content, making sure that we're going by those content outlines so you're studying the things that are important for passing your exam. That's the goal. You're going to learn a lot of things along the way or relearn a lot of things along the way. But my primary focus in creating these test prep materials are following the content outlines and making sure that you're covered and know what you need to know for the exam. So go check that out, meded101.com/store. If you're a nurse, med student, pharmacy technician, we've got study materials for you too. So go check that out. Find some good clinical practice pearls as well as preparation for your exam. meded101.com/store. All right, let's talk some individual agents here. So amitriptyline is probably, along with nortriptyline, two of the more common ones that I see. Amitriptyline is pretty sedating, so pay attention to that. I generally see it dosed at night if we've got to give this one or use it. Pretty strong anticholinergic adverse effects. So amitriptyline in an elderly patient, it's generally not a great combination. Again, a lot of this is dose dependent. So, if you use a baby dose, you may be able to get by with that. But as we escalate dosages, that tolerability is going to go down significantly. Amitriptyline, definitely see used for neuropathic pain, migraine prevention, sometimes fibromyalgia. And again, that dosing at bedtime is important. tends to be pretty dirty as far as hitting a bunch of different receptors, and so that adverse effect profile is pretty significant. Nortriptyline, so is actually the active metabolite of amitriptyline. It tends to be better tolerated. It's a little bit more specific for some of those serotonin and norepinephrine receptor subtypes, and maybe a little bit less sedating, a little less anticholinergic, again, in comparison to some of the other agents. Now, if you escalate that dose as we go higher and higher, that drug's going to get a little bit dirtier and hit some of those other receptors and cause more and more adverse effects. In practice, in geriatrics specifically, if we absolutely have to use a TCA, generally this is the one that I would recommend if that's your only choice there. Clomipramine, so interestingly, this is a pretty strong serotonergic activity. Occasionally see this in OCD, obsessive compulsive disorder. With that elevation in serotonergic type activity, obviously that can bring in serotonergic adverse effects, can bring in serotonin syndrome, maybe a little bit higher than some of the other medications as far as that risk goes. But with that serotonergic activity, we can also increase the risk for sexual dysfunction. So pay attention to that. It certainly can happen with all of these agents, and it is definitely a class effect. But clomipramine may be the highest there. QTC, cardiac complications, pay attention to that as well, particularly as we escalate dosages. Imipramine, this one actually hits those alpha receptors, so blocks those alpha receptors maybe a little bit more, so that orthostasis risk, a drop in blood pressure, is a little bit higher. So somebody particularly at risk for falls, for example, for dizziness, or they already have low blood pressure, imipramine may be a little bit higher risk in that patient population. Pretty strongly anticholinergic, also can cause some cardiac complications as well and increase QT prolongation risk. And I will point out, TCAs, one of the reasons, in addition to obviously kind of their broad adverse effect profile, but tricyclic antidepressants in the setting of depression, and particularly those with suicidal ideations, that they tend to cause a little bit more cardiac complications, particularly in overdose. And so if you've got that risk, serotonergic agents or SSRIs tend to be a little bit safer in that setting of overdose or high dose, as far as not having as high a risk of causing some of those cardiac complications. All right, moving on. Next medication, I got a couple left here. Desipramine. This actually tends to be a little bit more on the neutral side as far as sedation goes, maybe trending towards a little bit more activating. And the reason for this is the mechanism. It's got a little bit more of the norepinephrine reuptake inhibition. So with that, kind of less sedative type properties, we also potentially have less weight gain. So these TCAs generally are associated with some weight gain, which again, in younger patients, trying to lose weight, potentially that can be problematic. Desipramine may be a little bit better for not causing weight gain compared to some of the other TCAs. All right, last one I'm going to cover here is doxepin. This is very antihistaminergic, or it has high antihistamine type effects, which leads to a pretty sedating type medication. Also, where I see doxepin used in practice, usually it's somebody having difficulty sleeping at night, and oftentimes in combination with a patient who's having issues with itching and rash and those type of things, and kind of that dual combination of an itch at night along with insomnia those two combining to keep that patient up, that's probably the most common situation where I've seen doxepin utilized. And usually the nice thing with doxepin, we can get by typically with a little bit lower dosages. It hits those histamine receptors right away, even at fairly low dosages. So and there is a specific prescription product available for that as well. So that's kind of the unique clinical quirk with doxepin that could definitely show up on your exams. All right, well, that's going to wrap up the podcast on TCA, test prep, and practice pearls. Hopefully you found this episode helpful. If you did, do me a huge favor. Leave a rating and review on iTunes or wherever you're listening, and share us, friends, colleagues, students, anyone who could use some pharmacology education. I greatly appreciate that. We've got tons of study materials, resources, books, all sorts of different things at meded101.com/store. Go there. Your support, your purchases there go directly to help fund this podcast and help me be able to do it. So I greatly appreciate that. If you want to reach out to me, comments, suggestions, questions, mededucation101@gmail.com. I do my best to try to respond to everybody. I get quite a few emails, but that's one of the joys I get from the podcast as well, is hearing from listeners in, things maybe I could have done better, or, things that they may want to see on future episodes, or you just shooting me a message to say you enjoyed the podcast. I appreciate those as well. So greatly appreciative of that. Again, mededucation101@gmail.com. You can also connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Thanks so much for listening. Take care. Have a great rest of your day.